Perfect. Thank you everyone for joining us today. Let's give it one more second. All right, miigwech and merci beaucoup, and thank you for joining us today for our Lunchtime Health Sciences webinar on fundamentals of wound assessment and treatment and your role assisting clients with altered skin integrity. Delivered by Deirdre Drombolis, Physiotherapist, and the Director of Health Services at Giishkaandago'Ikwe Health Services. I'm Jennifer DeBaker, and I am the Programs and Partnership Coordinator here at NOSM University. And before we get started, I'll do some quick welcomes and introductions. So reminder about your microphone being off for the duration of the webinar. This webinar is being recorded and will be posted to our RS and NoDip websites in the future. If you have any questions throughout the presentation, please feel free to put them in the chat. I will monitor it. We'll also have a question and answer period at the end of today's session where Dee will answer any questions you may have. All of our previous webinars are now on YouTube, and you can find those links to those recordings on our RS and NoDip's websites under the resource section. In the spirit of truth and reconciliation, NOSM University respectfully acknowledges that our pan-northern campus is on the homelands of the First Nation and Métis peoples. The university building we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wahnapitaea First Nation and Fort William First Nations. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers who share their gifts and teachings with us so that we may better understand and honor their wisdom, and that all of the traditional keepers of this land. NOSM University will continue to practice reconciliation by listening, learning, and fostering a culture of mutual respect and trust. Next slide, Dana. Dee has been a physiotherapist in her hometown of Fort Frances for over 20 years, working at first at the local hospital and in 2017 moving to Giishkaandago'Ikwe Health Services to service the surrounding 10 First Nation communities within the Child First Initiative program. Most recently, she has stepped into the role of Director of Health Services for the organization. In 2007, she took part in the first clinical master's program in wound healing at the University of Western Ontario. And this started her passion for skin health and the role physiotherapists can play in this complex health concern. She has and continues to provide advanced skills and support the local hospital and family health team, as well as the home and community care program at Giishkaandago'Ikwe on an ongoing basis. Outside of this, she has participated in many best practice guidelines development processing, including Wounds Canada and the Registered Nurse Association of Ontario, and authored many papers around skin health. She was a long-standing member of Wounds Canada Board of Directors and continues to support ongoing professional development for them. Next slide, Dana. So merci beaucoup, miigwech, and thank you. Dee, thank you so much for your time today. We truly appreciate it, and we look forward to your presentation and an opportunity to ask questions. I'll now turn things over to you.
Awesome. Thanks, Jennifer. Welcome, everyone. I am just going to ask a quick reminder for folks to make sure you're on mute. So just everyone have a check to make sure, just because it can be quite distracting. And I know it happens by accident, this crazy old technology. You think we'd be good at it by now, but it's still tricky, I find. All right, let me get my slides up here. I will minimize this and hopefully you guys will get to see my screen. Is that good? Can you guys see?
It's perfect, Dee.
Okay, awesome. So yes, thank you so much. I was just sharing that there's a lot of information for us to go through today. So hopefully I will be able to share some stuff that's helpful for you and also maybe whet your appetite. This is a very complex issue, and unfortunately, no profession really learns a lot about it. We all just kind of scratch the surface. And so that's concerning because it's something that actually touches all of us across all patient populations. And so we really, I just think it's really important that we learn as much as we can so that we can help support clients, because altered skin integrity does have a really big impact on folks' lives. This is just my reminder for us all that we are going to learn about research, we are going to learn about evidence today, but we can't hold that out of our own expertise and our own experiences, and of course the lived experiences of our clients and their situations. So what might be best practice in one situation actually may not be best practice in another, and we have to keep that big picture kind of in our minds. So yes, what we're going to look at today is just hopefully scratching the surface of understanding the really complex nature of impaired wound healing and how this is going to impact the way we look at things and assess and make a treatment plan. We're going to look at something called the wound prevention and management cycle. And then we're also going to hopefully start to see how our different roles could be incorporated into a treatment plan and really be able to support clients who have altered skin integrity. And so really we need to start with the basics. We need to remember what our skin actually does. It's an organ, right? And it's very important. It has a lot to do with protection, right? It protects the inside of our body from the external environment. It is very important for sensation, right? It's how we kind of feel the world, right? It's important in thermal regulation, so that kind of gas exchange, right? When we're cold or when we're hot, you know, our little hairs stand up to help us warm up. And when we sweat, we have that kind of gas exchange. Excretion, so it is a way that we get rid of, you know, some toxins and those types of things that are held within our body. Super important for metabolism and that exchange, right? Vitamin D and all those things. This is the one that I think we forget sometimes, and how important our skin is to our body image and our sense of self. And when you do have altered skin integrity, I think sometimes we forget this impact. I guess it's just that reminder for us of how drastic skin integrity is to a person perceiving themselves as whole. This is the thing I want you to take home, though, is that your skin health is a very strong indicator of overall health. And if folks are having problems with altered skin integrity, it is because there's something going on with their health. And I think all of us, no matter what our background is, can see how we fit in to help walk a client along their path to have better health. So you have a role to play in wound healing for sure. When we're looking at folks with chronic wounds or wounds that fail to heal in that kind of typical time frame, really what we're trying to do is boost them through those phases of wound healing. And so we need to kind of revisit those phases of wound healing, because they'll help us see where we fit in and what types of things we should be looking for and what types of things we should be helping clients with. So this is where we get to review Physiology 101. So what are those stages of wound healing, right? So how do we go from, you know, a break in our skin to that being closed over? And there's 4 main stages, right? So the first one, hemostasis, right? So stop the bleeding. Inflammation, right? Get rid of the junk. Proliferation, let's fill it in. And then remodeling. So if we break those down a little bit further, I like to think of it as a house remodel, actually. So when we're remodeling a home, we have to first kind of turn everything off, right? So that we can progress. And that's really what hemostasis is about. It is about stopping the damage, right? It is about stopping the bleeding, stopping the damage, and so that we can move on. If you don't do this, you actually can't do any building up, right? So if there is continual sources of tissue trauma, we're not going to progress through, right? So we need to protect the tissue, okay? And so this is, again, where I'm wanting you to think about what your scope of practice is, what your area of expertise is, and how you might be able to help. And we'll get more into that as we go. Inflammation. So we get scared about inflammation, actually, but we need to remember that it's actually part of the natural healing process. And its job is to break down the dead tissue that's in the wound, right? So something's happened, there's been trauma, some tissue has died. We need to get rid of that before we can progress to building someone back up again. So again, this is about protecting an area from tissue trauma and allowing what needs to happen, because if you get stuck in this spot where there's ongoing tissue trauma, you're never going to get out of this chronic inflammation stage. Infection kind of has a bit of a part to play here, but just remembering that infection and inflammation are not always the same thing. And then we get to the good part, the proliferation, where we're starting to build up again. So what needs to happen here is that you need to have the building blocks, right? You need to have the nutrition, you need to have the hydration within your body to be able to build yourself up again, right? So if you're a dietitian or if you're an SLP, you can start to see where maybe this is an important role for you, right? To make sure that someone actually has the building blocks that they need. And that they're able to get them into their body, right? You also need to protect the tissue, right? Because if you start to have tissue trauma again, you're actually going to go right back to where you were, and we're not going to be able to progress. And then this is the other cool stage, the modeling stage. So this is where you're putting the fine touches on, right? We're making sure that our collagen align properly. We're making sure that we are building tissue that is going to be able to stand ongoing stresses as we move forward, right? So this is the stage where we're stretching, we're strengthening, we're lengthening, and doing all those types of things. Again, protecting though, right? Because we always want to remember that once we have a break in our skin surface, it actually never goes back to being the same strength, right? You're about 70%. And that's with optimal wound healing, right? So just remembering that in the back of our head. And this, I always just throw this slide up because it just reminds me that wound healing is very complex. There's a lot of cells and a lot of things going on at the same time, that it's a long time period, right? Like it's up to, so this slide is telling us, you know, we're up to 21 days. So that's kind of normal wound healing. Once we get past that, that's a flag that there's some stuff going on. And then remembering that remodeling and cross-linking actually takes up to 2 years, right? So we talk about a wound being closed, but not healed until that point, right? And it's also a good reminder that this is happening at different stages in the wound, right? So some parts of the wound might be in different stages than others. So just a reminder of how complex this really is. Oh, what's this slide? Oh, there we go. Sorry. So this is the wound management cycle, which is basically kind of the best practice recommendations that have been put out by Wounds Canada. And this is just a little pump for us here in Canada. We actually are kind of at the forefront of wound healing in terms of research and, you know, being progressive and having kind of a good guideline to make sure that we're kind of doing things well. I recommend you guys go ahead and take a look at their website. They have so many amazing resources, both for clinicians and also for clients. And you'll find some of the best practice guidelines are there, also available for free download. I would also like to highlight, when you look at this wound management cycle, it's actually the way that most of us in rehab science have been taught, right? You do your good assessment. From that, you kind of establish what your impairments are. You set some goals, and around that, you're going to pull together your treatment plan. And if you need to pull anybody else in, you're going to pull them in. You're going to actually implement your plan of care, and then you're going to continually reevaluate, right? And then the cycle starts again. So I guess I just highlight this because in the back of my mind, I always remember, like, when I'm presented with somebody with a wound, it's not unlike any other physiotherapy assessment that I'm going to be doing. It's just my focus is a little bit different, right? And so I hope that you can kind of see this as well as we move forward. And then this is just a reminder that it's just helping us to have this logical and systematic approach. It's constant and accurate multi-directional flow. So really that good communication is key, not unlike any other thing that you're going to be treating. And really we want to be thinking about prevention from the beginning. And as always, our client is at the core of all of our decision making, which is why they're in the center, right? So this is the fun part where we actually get to kind of go through and see and pull out what some of those impairments are that we might be able to assist a client with. Really, I think what I love about being a physiotherapist, and in particular looking at wound care, is that I feel like I'm in CSI, right? Like really we got to get down to the root cause, because if we don't get down to the root cause, it doesn't really matter what we put on a wound. It's not going to heal. And I think that is sometimes the misconception, because we get caught up in all these fancy dressings and all these things, thinking that that is what makes the difference. And it's really not. And I hope that that's another take-home message that you folks will get from today. So just looking at our assessment piece, and you're going to see things here that you probably already do for all of the conditions that you work with, right? You really need to look at the person as a whole, right? And not just the whole in the person, right? So looking at them, their physical and emotional needs, and you might have some assessment tools to kind of look at that. You need to look at them and where they are at, right? So they are more than just them, right? They are their socioeconomic circle, and they're the supports that they have, right? They're also the systems that they are contained in. So what someone might have access to here in Northern Ontario is going to be very different than what someone might have access to in Toronto, right? And we need to take that into context. And then there's the actual assessment of what's going on. And that's basically using all of your senses to have that good assessment piece. And really what your job is when you're doing this good assessment, and you may not be doing this in isolation, right? Like you may be doing this in conjunction with, say, a nurse or someone else who might have more expertise at the actual piece. But you're really trying to figure out why your client is at risk or does have delayed wound healing. And there's going to be lots of reasons, right? So let's look at that. What are the factors that affect wound healing? So they're divided up into two. So there's the very local, so looking at that area. So like if they have a wound on their leg, what are the things about that are impairing their wound healing? So the type and size and location, right? So a really big wound is going to take longer to heal than a really small wound, typically. And also where it is, like, is it in a spot that's getting continual tissue trauma from pressure, rubbing, friction, those types of things? Is it in a spot that has not very good blood supply? And that's my next point. Vascular supply is paramount. If you do not have adequate blood supply to an area, it is not going to heal. So that is always my first question when anybody presents me with a client saying, oh, geez, why is this wound not healing? I always ask, did you check their vascular supply? Now, that may not be something that you are comfortable with or something that is within your scope of practice, but it should be a question that you're asking your nurse buddy or your physician buddy that might be in your circle of care with this client. Has that been looked at? Has that been assessed? It is within scope of practice, for example, for a physiotherapist to be assessing this. So you might want to learn a little bit more about that. And I encourage you to do so. So what kind of things they're putting on their leg, right, can impact. I had one little lady who was in hospital with pretty significant dementia, and she had this wound, and it was very superficial, and it wasn't healing. And we kind of found out later that she was actually putting some of her condiments from her tray on her wound. Right? So, and there's also topical medications that actually are going to impact different steroids, different creams, those types of things. Edema, so swelling. Swelling is really tissue trauma from the inside out, right? If you think about now you're occupying space, you're stretching tissues, you're actually putting space between your vascular flow and the tissue, right? Because the swelling is in the interstitial space. So now the nutrients are not able to get to where they need to go. And conversely, you're not able to pull the waste products back in to be flushed back out. So it is really tissue trauma from the inside out. And maybe some of you can see where, oh, geez, I'm actually really good at treating edema, right? I have lots of tools to treat that. So just kind of keeping that in the back of your mind. Nerve innervation is a huge piece, whether or not there's actually good innervation to an area. So if there's decreased sensation, you can see how tissue trauma is going to be easier to happen, right? External forces. So if it's an area that's squished into a shoe or, you know, on a bed because our client is immobile, you're going to have some of those external forces on the wound. And then your wound environment. So I did say that dressings don't heal wounds, but they can also make things a lot worse if you're not picking the appropriate dressing to maintain the proper wound environment. I always akin dressings to symptom control. So they are like choosing the right type of pain reliever for your headache, right? Some of us do better with Advil, some of us do better with Tylenol. So it's about choosing that appropriate symptom control. We're also going to have factors that are systemic. So that person's overall health. And I think you can probably imagine what some of these are because they are some of the risk factors for a lot of the things that we follow in clients, right? So things like how old they are, right? The older you get, the more frail you often get and the more susceptible you're going to be to altered skin healing, right? Genetics, so there are certain things that are in our genetics, different valve disorders in our lower extremities, for example, and different things like that. Medications, so there is a whole host of medications that actually alter skin ability to heal. They mute your immune response. They do things like changing the way that your blood supply gets to areas. So I'm just keeping that in the back of your mind, and those might be questions that you want to be asking. Nutrition and hydration is huge. We talked about how during that proliferation stage, you need to have the building blocks, right? So dietetics is actually huge, and making sure that folks are able to get the proper nutrition that they need is huge. So they need to be able to swallow, they need to be able to find different ways to get the nutrition into them. Of course, smoking, alcohol abuse or use, and also other various drugs are going to impact your wound healing. And we know smoking's huge, right? It very drastically decreases the blood flow to your extremities over time. So again, it's pretty huge. So stress and depression, and also pain. So there's actually a lot of literature to support that not only does this negatively impact our client themselves, it actually also changes their body chemistry. And it tips it actually towards that inflammation stage where we know that we're not able to build up good tissues, right? So there's actual mediators in their body that are actually preventing them from healing. So the more that you're able to support a client, if this is a really big concern for them, the more that you're able to help progress them towards better wound healing. And I know as a physiotherapist, you have lots of ways to treat pain. You know, we all have probably some skills around supporting a client who's feeling stress, or there, you know, this might be an opportunity for social work or, you know, counseling or those types of things as well, if a client's ready, of course. Infection, again, is huge. And we talked a little bit about how infection kind of bumps the wound continually back into that inflammation stage, can't progress. If you're stuck in that infection phase, there's no way that you're actually going to close a wound. So you need to address that infection. And again, overall health and comorbidities, things like diabetes, you know, heart disease, CHF, COPD, right? They're going to impact your skin health. So any of the tools that you have to support clients in those areas is going to help improve their skin health. Ability for self-care is also huge. This, some of the things that we need to do to help a client close a wound actually asks a lot of clients. It often asks a lot of changes in their everyday life. And so we need to make sure that they do have the ability for that and or supports to help them with that. And just their environment is another huge piece to this, right? We always have to remember that our client is not just this person, right? And access to healthcare. So again, what people might have access to here is going to be different than other areas or wherever you are, because I guess we're together virtually. And funding is also huge. Whether or not people have access to specialty shoes or all these different equipments and dressings and these types of things is also a huge impact as well. Oh, why are we not progressing here? There we go. All right, so we've taken kind of that high level look of that assessment of our client. We are just going to take a few moments to dive into some of the more specific wound related assessment pieces. So actually looking at the wound, just so that you understand some of what folks might be telling you, or to draw you in and hopefully want you to learn a little bit more if the actual wound care piece is something that is interesting to you, because there are those of us that have wound care within their scope of practice, right? So you can actually do some of the wound care if you're interested in it, but I don't want that to be a stumbling block for folks being able to help clients if you're not interested in the direct wound care, because there's a lot that all of you are able to bring to the table if you're not interested in this direct wound care. But you need to know some of the lingo, right? We need to all be on the same page. So there is a mnemonic, I can't even say that word. There is a word that I use to try and remember what I should be looking at when I'm looking at a wound, and it's measure, conveniently enough. So the first thing is we always want to look at the size of a wound, because that's how we're tracking change, right? And I think all of us that are in the rehab realm are very used to using outcome measures to make sure that we are actually doing what we think we're doing, right? And that's all this is. We tend to measure length by width, right? And then use a Q-tip to measure depth. All right. And it's really, like I said, it's just a measure of progress over time. Really and truly, you should be seeing, 30 to 40% change in that wound size over 4 weeks. If you're not, there's probably something that you need to revisit. The next piece, and sorry guys, there's gonna be gross pictures. I probably should have warned you. The next thing we want to look at is the amount of drainage or exudate coming out of a wound. And this actually can tell you a lot because wounds that are infected tend to drain more, right? So that could be a cue. Wounds that are on legs that are edematous are going to drain more, right? Because fluid needs to go somewhere. The way that the fluid looks can also give you lots of clues as to what's going on. I will give you the caveat though, this wound looks really yucky, and it's actually because of the type of dressing. So just that understanding that sometimes your dressings are going to impact what your drip looks like. So we talk about scoring. So how much? So we're talking about none, scant, moderate, or large. Typically large is not good. Small is kind of usually where we want to be because a wound is going to drain a little bit. That's kind of normal. And we actually want there to be a little bit of moisture actually in the wound if it's a wound that has adequate blood flow. If it doesn't have adequate blood flow, we actually want it to stay dry. And then we talk about what it looks like. So, and I think Jennifer's going to share these slides with you, so you don't have to worry about trying to write this stuff down. So we talk about what it looks like. So serous is that kind of watery, kind of clear to yellow fluid that you'll notice. It sometimes like that fluid that you would see in a blister, like if you get a little blister and you pop it, it's that. And that's actually normal. That's actually what we want. The next thing is serous sanguineous. So that's basically that serous fluid that actually has a little bit of blood in it. And anytime you start to see any blood in your drainage, it actually is a cue that there's some tissue damage going on. Not always, but sometimes. Frank blood is what we call sanguineous. That's not good. We don't want that unless you've just debrided something. Seropurulent is drainage that is kind of thin, but it has a bit of a color to it. It's now kind of white and creamy. It might smell bad. And purulent is that frank, thick pus, basically. Now, we often get excited about that, and we maybe should be. However, I always just like to remember that anything that's purulent is just telling me that there's probably dead tissue and there's also white blood cells. That's basically what that is. So while it may indicate there's an infection, it doesn't always. So I guess just keep that in the back of your mind as well. And then we talk about how healthy a wound looks, right? Because we can have different types of tissue in the wound bed, and the tissue tells a story, right? So that top wound that you see, that nice kind of beefy red, kind of pebbly looking wound, is actually what we want. That is collagen that's growing, that is new blood cells that are budding, it is epithelium that's growing, right? So that's actually what we want to see. In the middle there, you see a wound with slough, what's called slough on it. And that tells me a couple things. It tells me that this is a full thickness wound because anytime there's necrotic tissue, that's typically necrosed fat, and that's what we're seeing. Okay, so we're looking at a full thickness wound. It's also telling me that there's ongoing tissue trauma here, whether that's from infection or from edema or from pressure. Tissue is continually dying, and so that's something I need to do something about. Typically when you see blackish scar, which is the picture on the far right, so a couple things could be happening here. Again, it's ongoing tissue trauma, right? That's dead tissue on the wound base. If it's very dry, that gives me concern to think about blood flow, right? So if we talked about how wounds typically want to have a little bit of drainage. If something's very dry, it may be because there's not the best blood flow to it. And of course, nothing's ever simple. Often we have wounds that are a mixture of all of these things. So when we're talking and describing and engaging with one another, we often talk about how much, so percentages of the wound bed. So, part of this wound bed is healthy, part of this wound bed is not healthy, and there's some ongoing tissue trauma there, right? So these are just the descriptors that we just talked about and the different tissue types, what they look like. And we kind of talked about those, so I won't review that. So of course, we talked about how important suffering and pain is. So the S in measure, just remembering that we're going by that mnemonic, is pain and suffering. And so just understanding whether or not a client has pain in the area, that indicates, you know, some stuff's going on there, right? Whether it's just pertaining to addressing change and moving that area, or if it's, you know, all the time, the changes in pain. Pain tends to be a red flag for me, especially in folks who are diabetic, because often folks with wounds on their feet get wounds on their feet because they can't feel their feet. And so if they start to tell me that they're having a change in pain in their feet, that's a red flag for you. And of course, thinking about ways that we can address this, right? So there's pharmacological ways that we can address pain, but there's lots of things rehab folks can do for pain too, right? And just because, you know, a modality or some of the tools that you use for, say, for example, a fracture or someone who's torn their rotator cuff, we can use those to help, right? We can use those to help folks who have pain from a wound as well. And then we want to look at the whole wound, right? So sometimes wounds are more than just the break in the skin, right? There's undermining. And so you can see there that they have a little Q-tip and they're kind of poking underneath the skin surface. And then there's such things as sinuses or tunnels. So in practical terms, undermining often tells me that there's friction and shear happening. So what's happening is the tissue underneath the skin is actually kind of being frictioned and it's actually kind of coming loose. And the skin's kind of separating. So you're ending up with that undermining, right? So again, red flag, undermining, friction and shear. Sinuses tend to tell me that there's an infection going on. So tissue's being degraded by the little bacteria bugs as it goes. So yeah, that's just kind of a tip practically there if you're hearing these things. And then the R is to reevaluate, which I think rehab professionals, we kind of have that already ingrained in us, that we need to make sure that what we're doing is effective. And if it's not, then we need to revisit our treatment plan, or do we need to do further investigations, right? So just that reminder. And then the E is edge. And so that we can't just look at the wound, right? We have to look at the tissue surrounding it, because that gives us, again, an overall idea about the health, right? And so we need to make sure that that tissue is protected, that you're not seeing ongoing evidence of tissue trauma like bruising or redness. Redness sometimes indicates inflammation and or infection, right? And then the other piece that I will just mention here, which is maybe a hook for some folks, is that when we're looking at, oh, sorry. Oh, I took that out. I think I took it out, did I? No. Is that when we're looking at the edge and investigating whether or not your epithelium is actually closing over, that's where some of your modalities for wound healing can come into. And I think we'll talk a little bit more about that near the end here. I do just want to mention that there are actually assessment tools out there. So that little mnemonic is, I guess, just a way to structure your assessment. But if you actually want to use something that gives you a number or gives you that outcome measure to kind of do pre and post, these are some examples. I will say, however, the pressure ulcer scale for healing has been validated. It says pressure ulcer, but it has been validated for use in all wounds, with the caveat that it may not be as accurate for diabetic foot ulcers because they tend to be smaller in size. The photographic wound assessment tool is actually validated to show change. Whereas the leg ulcer measurement tool and the Bates-Jensen wound assessment tool are actually more descriptive tools. So they are actually really good at telling you what you're seeing and giving you a good tool to communicate. They are less good at tracking change. So if you're looking for something to track change, I encourage you to do a little bit of a dive deep, or we can have some conversation and you can ask me questions after about the first two. And yeah, the bottom two are more for descriptive. And this is something we are all really good at, so I am not going to spend a lot of time, but just remembering that we do want to set goals for our clients. We want to make sure that they are SMART goals, right? Because we want to make sure that we are specific. We want to be able to track that change. They should actually be realistic, and they should be something that is important to the client, and it should be timely. So when we're looking at wound healing, my first goal that I'm looking at is actually healability. So what do we mean by that? So a wound that is healable means that the patient, the system, and the wound factors are in alignment for healing, right? So we have a wound that has good blood flow. We have someone who is able to work on or is in kind of their best health. They are in a system where they can get dressing changes. They can get access to the appropriate dressings. This wound should heal over time. However, that's not always the case. We also have wounds that so maybe the wound itself is healable, so it does have good blood flow, but there's some other factors that are preventing this wound from progressing. So for example, we're not able to offload the area currently because of waiting for equipment, or maybe difficulty being able to utilize an offloading modality. Maybe they need to have a vascular procedure, so they are able to have their blood flow improved, but they need to have this procedure first. So these are wounds that are what we call maintenance wounds. And just remembering that this is not like a definitive label, right? It is kind of a fluid point. And sometimes a wound can come in and out of this maintenance stage. I think it's really important that we have good conversation with our clients around this, though, so that we have realistic expectations about what's going to happen to them. And then there's wounds that actually are not healable. So for example, this is a picture of a wound with no blood flow, right? And so it is actually inoperable. And so this wound is not going to heal. So our goals of care are going to be different, right? Than that first person whose wound is, we've got all the boxes checked. We are able to, implement a wound healing treatment plan and progress through that. For this patient, what we want to do is protect that area, right? And you still might have a role to play there, right? If you're an OT and you're really good at, providing pressure redistribution, if you are a physio who are able to give someone, upper body exercises so that they can keep mobile still while protecting this area, right? So there's still a part to play. In terms of the wound kind of management itself, these are wounds that we keep clean and dry to make sure that we're minimizing infection and we're not opening up an area for increased tissue damage. People who are dying also fit in this category. I think sometimes we forget that our skin is an organ, and when the body shuts down, it also shuts down, right? So those are just some examples of non-healable wounds. But as we all know, wound healing is not the only goal. And so I guess being open to that discussion with clients. So for example, I had someone who had a horrible wound actually on the bottom of his foot and was not actually able to not go to work. And so he worked on his feet, had to wear steel-toed boots at work. So any of my offloading devices that would promote wound healing were not things that he could use at work. And so we did a lot of problem solving to protect his foot best we could at work. However, he knew that he had, once some time went by, he actually had, I think it was 6 to 12 weeks of vacation that would be coming to him. And so our goal was actually to enable him to go to work until he got to that point where he could actually take some time off, right? And so that was more important to him than wound healing at that point. So I think rehab staff tend to be really good at remembering this, but I just like to always throw this up here to remember that wound healing is not the only goal, and just to be collaborative with that. So our third step, if you remember going back to our wound management cycle, is pulling in all the team members. And at the beginning, I had kind of talked about how wounds affect every patient population. They don't really belong to any one area of healthcare, right? It's not like you go to the cancer care center, to have your cancer dealt with, right? And so that's why we really need to draw in this team. And so just being cognizant of all the different people that might be able to bring their skills to the table, really making sure you have that good communication and engagement with the patient and the family and the system around them, right? And communication is key. I think we all recognize the importance of good communication. So then step 4 in our management cycle is to establish and implement a plan of care. And just remembering that we really are trying to balance kind of what we're seeing and what our clients are telling us with what the evidence tells us, right? And also what the wound is telling us. And that's why, again, it's so important that you collaborate and just think about what you can bring to the table to help implement this plan of care. This is my goal always, is to optimize health. And I'm hoping that you can kind of see how important that is actually to support clients with impaired wound healing. I'm going to go over this really quickly because we are going to run out of time, but just remembering that there are some cornerstones for local wound care. That includes debridement, balancing infection and inflammation, moisture balance, and then addressing the edge of the wound. This is old literature from 1967, actually, is that a wound with adequate blood flow heals faster in a moist environment, not too wet, not too dry, like your eye. So that's where that symptom control with your dressing is important. Okay, so again, this is just my reminder that what you put on the wound is less important than what you're taking off. So are you taking off sources of tissue trauma? Are you making sure that the area is protected? Are you doing that debridement to get rid of the kind of dead, yucky tissue? Are you managing the moisture balance? And I think maybe some of you are starting to see where you could fit in here. And then this is my pump for adjunctive therapy. So there are actual, if you are interested in actual techniques to improve wound healing, there are actually a lot of adjunctive therapies that physiotherapists would use for other areas of physical modalities. And they have actually quite good evidence, well, very good evidence actually, to show improved wound healing. So just to kind of keep that in the back of your mind, E-stim is the one with the most literature to support its evidence. And again, that's a whole probably weekend course, so we won't go into too much detail there, but just to know that it's there. All right, so now what we're going to do is just take a few moments, and I think we have good time, just to really hammer down on to some of the impairments around three more common wound types. And I'm hoping that you can kind of see where some of your areas of expertise would be very valuable in helping a client. So pressure injuries are just that. They are wounds that are incurred because of the tissue damage that happens when tissue is trapped between a bony prominence and the surface that that bony prominence is on. So what really actually happens is the blood vessels and the capillaries get closed because of that pressure, and the tissue dies, right? And that ends up having the skin opening up. This is how I think about pressure injuries, and this is something that I created for an article I wrote a few years ago for one of the physiotherapy magazines that comes from the Physiotherapy Association. So really the hallmarks of a pressure injury is decreased activity, decreased endurance, decreased range of motion and strength. So then that means that a person is not able to reposition, right? This is compounded by skin moisture. So if they happen to be incontinent, or if they already have a wound and it's draining a lot, drooling, those types of things. Their health status and pain, right? So if someone's in pain, they're not gonna reposition necessarily, right? And then the impacts of friction and shearing on their bodies. And so that ends up having increased pressure. Then you have that capillary damage and or closure, and then you end up with a pressure injury being created, right? And so OTs, PTs, you know, we have lots of tools and techniques that we can help people with their increased activity, to increase their endurance, to help them build strength and range of motion. So just, I'm hoping that you can start to see where this fits in, with the caveat that we need to protect that tissue, right? So all the things that we need to do need to be safe so that we're not causing ongoing tissue trauma. The next type of wound that I want us to narrow in on is venous and or arterial leg ulcers. So these are the wounds that I get actually most excited about, because there's some really cool literature and pathophysiology around the calf muscle pump, right? So remembering that our venous system is a little bit different than the arterial system, right? It relies on the valves and actually the action of our calf muscle in order to bring blood flow back up to the heart. And so basically in that way, our calf muscle actually works like a second heart, right? And we know lots of ways to strengthen that muscle, to build endurance in that muscle, to make sure that that muscle's functioning at its utmost, right? And this is just a nice schematic of how it works, right? So you can see here, this person's doing dorsiflexion, plantar flexion, which is very important in our gait, right? And so that's that reminder that our calf muscle pump is actually most active when we're walking in our optimal gait. So any ways that we can help someone achieve that is going to help their calf muscle pump, which is going to help a person be able to manage that. And let's just look a little bit more at what causes those venous leg ulcers. So really they end up because a person has ambulatory, what's called ambulatory venous hypertension. Basically, the fluid stays in their legs because they don't have the ability to get that pooled blood back up to the heart to be recycled, right? So that can be for a lot of different reasons, and I'm not going to go into them too much right now. However, the important thing is to know the impairments behind it, right? So it's that abnormal muscle pump function, which is often accompanied by decreased range of motion and decreased muscle strength of that calf muscle. You're going to end up with things like pain, decreased mobility, decreased endurance. You're also going to end up with neuropathy, challenges in balance, and those altered biomechanics in their gait. And it's sometimes that chicken before the egg kind of situation, right? So did they have these things before, and that's what caused their abnormal muscle pump function, or vice versa, right? But again, I'm hoping that you can see where you might have some skills to help a client navigate this, right? The last one we're going to touch base on here, and then hopefully we'll have a few moments for questions. And I know this is really fast, so I'm hoping I'm just kind of sparking your interest. Are diabetic foot ulcerations. So this is how I view diabetes. So a person who has poorly controlled diabetes is in a state of chronic hyperglycemia, right? There's too much glucose floating around in their blood. There are certain cells in our bodies, namely our white blood cells, our endothelial cells, and our neural cells that don't like this. And so they end up being damaged. And each of those cells have important roles to play. And because of the damage, you're going to see impairments resulting, right? So the damages to the, and that impacts a person with diabetes ability to heal and or their risk for altered skin integrity, right? So altered white blood cell function means that they're going to have a higher risk of infection. They're also going to have a muted immune response. So we're not actually always going to know when they're in trouble because they're not going to exhibit those typical signs and symptoms. Your endothelial cells are the cells that are in your blood vessels, right? And so that impacts your skin perfusion, right? And we have talked about how important blood flow is for healing, right? And then the other really big piece for folks who have poorly controlled diabetes is the trauma to their, you're probably going to hear my cat, I apologize. The trauma to their neural cells, right? So they end up with neuropathy, and that is autonomic, motor, and sensory neuropathy, right? So the autonomic piece has to do with their overall skin health. And so do we have any tools and tips to help them, you know, keep their skin healthier? The motor piece is going to result in decreased strength and range of motion, and it's going to change the way that their foot works, right? So do we have tools and techniques to be able to help with that? And the kind of the result of those altered biofoot mechanics is abnormal pressures on the bottom of their feet. So basically, folks will end up weight bearing on spots on their feet that they're not really supposed to, and then you end up with tissue trauma because of that. Sensory is actually the biggest concern. So folks will end up with decreased proprioception, so that impairs their balance, and it also changes that plantar pressures on their foot. But the biggest thing is that folks with sensory neuropathy end up with loss of protective pain sensation. So they end up with repeated trauma to their foot that they don't know is happening, right? And this is also kind of the crux as to why it's often hard to have folks engage in their care because they don't feel their foot. So they're not going to be concerned about something that's not really bothering them continually, right? Like if you broke your ankle, if you stepped on it, it would hurt typically, right? And so you don't have that kind of gift of pain to remind you. And please do not underestimate how little folks feel when they kind of get to this stage. I had a gentleman who played 18 holes of golf with a golf ball in his shoe, and he did not know that it was in his shoe. He could not feel it. He didn't know until one of his friends that he was playing with actually said to him, "Oh, look, there's like blood on your shoe. What happened?" Okay, so and unfortunately, as a result of that trauma, he ended up losing his leg. So it's huge. And they will tell you they can feel their feet, but they can't. They can't. And again, this is just a reminder of that. This is one of the things that I do with folks is I often trace their foot, and then I will either trace their insole or kind of put their footwear over top just to kind of show them. So this is a real person. So this person was squishing that foot, so that tracing is her foot, into the shoe, and couldn't figure out why she was having ongoing tissue trauma to the outsides of her foot. And sometimes it takes simple visuals like this to kind of help remind people about what's going on. And I'm just going to skip past this, but this is just to explain a little bit more about that motor neuropathy. So muscles atrophy, they tighten, and you end up with deformities, right, in the foot. And you can see here how now this person has increased pressure on that metatarsal head or on the tip of the toe where they're not really normally supposed to, or conversely on the top of the foot. So just that kind of visual there for that. And of course, step 5 is we have to reevaluate, right? Are we meeting our goals? Why not? What do we need to do differently? Maybe our goals weren't very good to begin with. And then we need to make sure that we're able to have our mind on prevention and reducing risk ongoing. So that's just reminding us of this cycle again. We've kind of touched a little bit very quickly on all of these things. And just that reminder of treating the whole person and not the hole in the person is actually paramount if we are going to enable a person to have better skin integrity. Yeah, so I think that's it. I think we can probably open up to, and these are some really great references, and I have more references too if you actually want some articles, but I'm just directing you to some places that have some really good resources. Yeah, so I guess we can open up to questions.
Thanks, Dee, so much. That was a wonderful presentation. So feel free to take yourself off mute to ask any questions or put it in the chat. The quiet bunch today.
They are. And I guess my question to you all too would be like for some feedback if there's more that you guys want to learn about too, right? Because then we could have potential for expanding. Because I know that that was very quick and very brief, but like I did a whole master's program on wound healing. So there's a lot more that we can learn and share together. So yeah, just provide that feedback as well.
Gee, so Mary Lynn said, so far she's a newbie to wound care. What would you suggest as a starting point after today's session?
So Wounds Canada is a good place to start always. They have really good resources. They do have trainings. They are meant to be kind of interdisciplinary, so I'm not sure. A follow-up workshop, I sure can. It depends on what your background is. I do know that OPA, if you happen to be a physio, does have a series of modules, and we're actually in the process of redoing them. We are also going to be doing a conference in Thunder Bay on June, I think it's 2nd, 3rd, and 4th, around wound care. And so there will be that opportunity as well. I don't know if I answered your question there, Mary Lynn. You can also reach out to me, and I can forward you some more places to learn. Oh, yes, so there is. However, that's not necessarily my area of expertise. So yeah, I would encourage you to do some research. I do have a colleague, her name's Chris Frazier, that I could connect you with as well. If you wanted to connect, she's kind of an expert in wound healing and the role that dietetics plays in that. So if you want to reach out to me, I can definitely connect you.
Thanks, Dee. And we will share Dee's email with everyone so that she can field any other questions.
For sure. Yes, Sharko. Yes, that is a huge whole other thing. That's like a thing on its own. But yeah, thank you for that. Oh, heel booty versus floating. So if you look at the literature, floating, completely offloading the heel is actually what's kind of the gold standard. However, that doesn't always work well, right? So there's lots of instances where basically the best pressure redistribution and or offloading is the one that the client uses and you're able to use in a good way. So that's kind of where that evidence-based practice circle, that little triangle where it meets. So yeah, so that would be my thoughts on it. Offloading techniques, yes. Okay, that's good to know. So I will actually take that feedback because we are going to be offering some workshops in conjunction with that conference as well. So I'll bring that back. And yeah, like if Jennifer and the folks want to bring me back to do more stuff too, I'm happy to do that as well.
Yeah, thank you, Dee, so much. And I'm sure there was such interest in wound care. We'd love to have you back. If there's any other questions, feel free to ask. We do have a few more minutes.
And they did mention to me about, because you're having your in-person gathering as well in May, right? So, I mean, there's opportunities there as well.
Yes, we are doing our in-person preceptor appreciation event May 12th. It will be in Thunder Bay this year. So if you have not joined our mailing list, please do so, but that information will be sent to you. And we're looking at clinicians to present abstracts. And so we mentioned it to Dee, so hopefully he'll submit an abstract or present at our event.
Awesome. Well, thanks everyone for sharing your very valuable time with me today. I know time is like the most precious of commodities. So hopefully there is something good there for you all.
Yes, again, thank you so much, Dee, for presenting during your lunch hour as well. And I hope everyone has a wonderful afternoon.
Awesome.
Thank you.
Bye, everyone. Have a good rest of your day.